Welcome to week 8. You know, a lot is going on. We have an exam next week. And next week's exam, make sure that you come to class a little bit earlier so that I can get you signed up, and in there, and make sure we start on time. And after class, we're going to be doing a first part of a HESI review. So you're going to get actually week 9 and week 10 are going to be HESI reviews. I'm going to be trying to help you score the best that you possibly can on it by going over those key concepts that I've seen on HESIs. Now, I've never seen a HESI exam. I do not know what questions are there. All I know what concepts that can be covered. So that's what I'm going to be doing with you, going over it. I don't know if I'm going to make a PowerPoint yet or if I'm going to be doing a slideshow. I'm working on that this weekend to make sure that you get what you need so that you can be successful. I know HESI is always everybody like, I do great in class and then I get to HESI and I'm like, ugh. So I'm going to try to get you guys the grades that you all deserve. So I'm going to work hard to give that to you. And then it's going to be your job to go back and study the information I give you, okay? So I'll work as hard as you guys work. And I hope that you all do really well on it. So week 8, couple things that are due. Remember, discussion questions are due. You have the HESI case study, urinary tract infection and burn. We'll be doing quiz 5 at the end of class, which is on this week's information. And this quiz has a lot of select alls. Okay, just to give you that warning that it's just not one concept to learn. It's a lot of things about one diagnosis. And then your NCLEX questions. If you haven't turned in your initial discussion question, just get it in by Sunday. I'm okay with that. I understand sometimes Wednesday comes and you forget. So just make sure that you get all of it in by Sunday. It's got a really good information on this discussion question, which is on, of course, this week's information. So next week, as I said, after we do our quiz, I'll be doing first part HESI review. Week 10, I'm going to be doing the same. And then if we need to, we can meet and do a discussion question to help you. And I'll be working on that also if it's something that you all want, but I'm trying to help you as well as I can. Anybody have any questions? Okay, this week is 4 different chapters. We have one on the urinary system, skin, metabolic, childhood communicable diseases, bioterrorism, natural disasters. What I have done is I broke it into 2 parts. Now, I think that I really need to lecture on the genital urinary and I need to lecture on metabolic. Those are 2 big concept areas that I can't not just give you something little. I must do a PowerPoint and cover them. But when we're done with those 2, I'm going to do a Kahoots. Now, these Kahoots will cover those 2 chapters, but it's also going to cover the other 2 chapters on skin and childhood communicable diseases on it. So you're going to get an instant, quiz type exam on all of the chapters immediately, after. It is 56 questions, I believe, or 57. So it really is comprehensive. So in your exam, like I had said, if anybody's listened to the recording yet, there is a lot of cardiac respiratory, but there's a lot of this week. There's 4 chapters. So hopefully in the Kahoots, I have given you everything that you need, okay? And that's your big hint. So let's start out with genitourinary. Anybody have any questions? I hear somebody moving. Oh, I found you. There you are. Good. All right, let's go ahead and start out with genitourinary, chapter 29. Genitourinary, we're talking about kidneys, we're talking about ureters, we're talking about bladder, we're talking about penises and conditions of those, and anything to do with urine, okay? So one of the things we don't think of when we think of, genitourinary problems is sexual abuse. Well, think about sexual abuse in the areas of the body that's being abused. It is going to be the perineal area, the genitals. So sometimes you're going to see a change in a child's behavior. So that physical, emotional, something's going on there. But there's other things we might see. Urinary frequencies. We're going to see all the signs of a urinary tract infection because it's all that redness and urgency and frequency and, maybe foul smelling urine. Could be all part of it. You might find that this child all of a sudden is doing excessive masturbation. I mean, many children, in their own rooms, in the bathroom, they do it. Some of the younger kids don't know the difference, and you might see them in public. I know that younger children, when you get to be about preschooler, toddlers too, but it gets more pronounced as preschoolers. They start, in masturbating and finding and looking at their organs and knowing the difference of males and females. And sometimes they're in public and they're, touching themselves. I know that my grandson, who's now 6, all of a sudden found his penis and was touching it a lot. And all I tell him is, if you want to touch yourself, go to your bedroom or go to the bathroom. I don't need to be seeing that. I don't make it a big deal because it's part of their growth and development. It is normal to touch yourself, okay? You might see endocaprices where that you have stools that are hard, and then you've got a little bit of juice, mucus in the intestines that will leak out. And you see that in the underwear. It's just different than just a bowel movement. These kids get what we call night terrors or severe nightmares. Maybe they think the person who's abusing them was coming after them, and they get to that point, depending on the type of abuse. A child who's already potty trained could become, wetting their bed at night. And then, of course, that irritation, that redness, anything down there could alert you something's going on. The youngest child I've seen that had sexual abuse, it was either 3 or 4 months old. And we sort of understood it by the redness down there, and the vagina just looked more open than it really should, because it's usually just pretty flat. So those things, remember, that's going to alert you. And remember, our job as nurses is to protect our client, our patient, and especially children. They don't have voices. They don't know, was this good, bad behavior? They're confused, they're conflicted, especially who's doing these things to them. There's all sorts of diagnostic procedures we can do to check your urinary system. It could be as simple as a urinalysis, and that's the first thing we do. Urinalysis, culture, sensitivity, and then we do all sorts of x-rays and ultrasounds and putting fluid in the bladder, seeing if it goes up, if there's any reflux going into the ureters, causing frequent hydronephrosis or pyelonephrosis, infection in those kidneys. I mean, all of these things are done depending on what's going on with the child to figure out, is it a structural problem or is it that they're just not wiping themselves proper, right? Because it could be as simple as wiping themselves back to front in a little girl, because they've got these little short urethras that are wide open. And, that E. coli could go right in there. Now, how do we describe urinary dysfunction? There's lots of words, so a lot of dictionary here. Dysuria is difficulty in urinating or painful urination. They're going to be frequency, which means they're going a lot. Now, urgency is when they can't hold it. as in if they don't run quick when they need to go, they could, urinate, being incontinent. And it's only because for whatever reason, they can't hold it. So frequency is going a lot. Urgencies when they got to get there because they can't hold it. Nocturia, urinating during the night, and enuresis, having incontinence at night, urinating a lot, and of course, not urinating much at all, oliguria. Now, abnormalities of the urinary tract. A lot of these abnormalities are little boys. Now, we know at birth, you go to the pediatrician, he's going to be checking the testicles and checking the penis, making sure everything is correct. Now, one of the things that can occur is the foreskin is so tight, you can't pull it back over the penis. And you're going to say, well, what's the big deal? Well, between that foreskin and the penis is an area that can collect debris called schmegma. And schmegma is like a petri dish, and it can grow bacterial, get into the urethra, into the bladder, and cause a lot of infections. My grandson at birth had an extremely tight foreskin, and I slowly tried to get that foreskin down to clean it, trying to show my daughter, because I know those situations that can occur. Well, as much as I tried, I couldn't. And then my daughter decided, okay, let's get him circumcised to prevent problems. And that's called phimosis. That's when you can't get it down. Now, sometimes what happens is you're cleaning it, you pull it down, and it gets stuck and you can't pull it back. That is called paraphimosis. Now, is that an emergent? Is that an issue? The absolute answer is yes, it is. If it goes down and it's constricting the penis and it's constricting blood vessels, it can cause damage, cause necrosis and death of tissue. So if you ever see that, you need to tell the charge nurse so they can call the doctor and they can do treatment to get that pulled back up as soon as they possibly can. This is not a wait till later and try again. This is, it needs to come, needs to be able to pull it back now. Now, another thing that can occur is that the urethra doesn't come out the tip of the penis. It comes out ventrally or dorsally, and those names are different. So you don't have that whole opening to the end of the penis. It stops and it either comes on the bottom, called hypospadias, or is up top, called an epispadias, anywhere up top or anywhere on bottom. Now, most of the time, they repair these because they want the child to urinate normally, right? One of the things about correcting anything with this, they need to do it before they're potty trained. So before 18 months, it should be done. Now, one of the things that can be an issue is you cannot circumcise these children. Now, when would that be an issue? Well, what if you're Jewish? Don't they do that brisk thing where they cut the penis? The rabbi comes and do it. It's this big, celebration. Well, you cannot do it because what they do with these surgeries, they literally fillet the penis in half and open it up, make a tunnel so that it can go all the way to the tip. They use the foreskin to help close it up, and then they put in a catheter to let it sit there so that that lumen can solidify, so that the lumen will go from the bladder to the end of the penis. Now, what do we as nurses do with that catheter? The answer is nothing. We leave it there and we make sure it's inside the diaper because it's leaking urine out the end of it, okay? So it can be repaired. It's before they're potty trained. And these are some lookings like it would look like, okay? I've seen one of these done and one of these repaired. And that little kid actually had something called Pierre-Robin syndrome, which has multiple other things that go on. Sometimes they're related to syndromes. Now, sometimes the internal organs are not born inside the body. I've seen it with stomachs called gastroschisis, and I've seen it with the bladder called bladder exstrophy. And all it means is during intrauterine growth, that skin didn't close up over that organ, so it was born on the outside. It still is a good organ. It's not malformed. It works correctly. It's just on the outside of it. Now, we like to get it back inside the body as soon as possible. What is our nursing concerns with a bladder born on the outside? Well, remember sometimes urine can leak and it's acidic, right? It could cause a lot of irritation to the skin. So we need to prevent the skin and the bladder from becoming excoriated and irritated. We also need to keep that mucosa of that bladder nice and healthy so that when we finally are able to stick that bladder in, because they have to sort of slowly push it in there because it was closed tight, there's no room. So they got to slowly every day, the urologist, urosurgeon, or the gastroenterologist for the stomach, slowly push it in there. These kids must stay positioned on their back. So by gravity, the bladder can go in there slowly, okay? So our concerns is prevent infections, keep the area nice and moist, and protect the skin from excoriation or irritation. And that's the way we do it. Remember, everything works the way it should. It's just outside. Well, sometimes there's something that obstructs the flow of urine. I mean, you've all heard of kidney stones, and they hurt, and they just block something, especially if they're in those ureters and they're jagged all over the edges. Trying to get down, it's really, really painful. You know, I've actually seen, I was telling the earlier class, it's on an adult, but it sort of describes the pain. It was a sergeant of a police force came in with kidney stones and he was crying, it hurt so bad. And I said, this is what you call male labor. It's just like what women go through to have children. It is extremely painful. Another thing that can happen is the ureters are kinked and the urine can't go down. So the kidneys fill up and cause hydronephrosis. You can have a lot of cysts in your kidneys. And then sometimes, for whatever reason, you don't have the proper parts and urine can't come down to your urethra and come out of the body normally. So there's something for that we do for the adolescents. Remember, adolescents are very into their body image, right? So if the urine can't come out normally, it should be in a urostomy, like a colostomy, but urine coming out. But an adolescent having a bag on their abdomen is, you know, very difficult. So we do something called an ileal conduit. And all it means is we put those ureters connected to the intestines. So it comes out the rectum, but it's not a bag that's attached to the body. And that really helps with their whole self-esteem, sexuality, and all of those sort of things. So urinary tract infections, most common of all the urinary issues, disorders that we have, more common in girls. Why? As I said earlier, there's a short little urethra right there next to the anus. And in potty training, they wipe a little bit the wrong way, and the intestines, the stool has E. coli in it, and it goes up, it's in the bladder, and now you have urinary tract infection. And again, it could go up into the kidneys and hurt the kidneys also. Another thing that happens with getting urinary tract infections is little girls love those cute little tights, and they're adorable, but they hold in moisture and heat, and it creates a good environment for infection. So, oh, and bubble baths. Little girls shouldn't take bubble baths. As much as they love them and they smell great and play with the bubbles, they're sitting in dirty water and their urethras are so short, again, goes up into the bladder. So how do we treat urinary tract infections? Well, put them in white cotton underwear, not colors again, white cotton underwear, increase their fluids. If they are sitting, holding their urine, we should say, get to the bathroom, go now, because holding that urine can cause it. No bubble baths, and again, wiping from front to back and teaching them close. Now, acid urine is what you want to keep, because infections love the opposite. They love alkaline. So what can you drink, the little girls drink, in order to keep their urine more acid? Well, most of you will say cranberry juice, right? Apple juice is one of them too. So apple juice will keep it more acidic, and again, will help decrease the amount of infections because it keeps the urine acid. What do you see and how do you treat these children? Well, if you have a young kid under 1, remember their immune systems are very weak. They haven't been built up yet. So usually an infant, 1 and less, many times they'll admit them for IV antibiotics because they don't want to mess around with just giving oral antibiotics, because they might need more than 1 antibiotic. And, these children, we could kill the kidneys, and these kids could go into urosepsis because we're not treating it as quick as they could. Now, older kids already have a little bit of an immune system, so they are absolutely fine to go home and be on some oral medications, antibiotics, okay? Again, making sure they're drinking and making sure that they're urinating when they need to go. So what are we going to teach parents? Clean it. If you have a young infant, make sure that you clean each diaper change. Clean it front to back, and avoiding bubble baths. Again, if a kid is in a bubble bath, they say they can urinate immediately after. But what happens with kids, especially little girls? You put them in a warm tub, they're just going to urinate, aren't they? So do they have enough urine to urinate when they get out? That's, my question there. Again, white cotton underwear, loose pants, not those tight ones, and again, increasing fluid intake. Nephrotic syndrome, or nephrosis, is an inflammation of the kidneys. I'm going to say this twice. It has nothing to do with kidney failure. Nothing to do with kidney failure. So what happens? Well, the kidneys say, hey, protein, I don't like you, and starts excreting massive amounts of protein. So protein is gone. You're going to see decreased protein or albumin in the blood. So, and you're going to see 4+ protein in the urine. These children will be immunosuppressed at this time. We give these kids some prednisone. What are we going to be monitoring for these kids? Well, nephrotic syndrome, because of the loss of protein, they get swollen because the body wants to look for a place. So the albumin or fluid in the body wants to be isotonic. And because of all this protein loss, they are not. So they go interstitially to try to make the balance. So where do you see this edema a lot? A lot of times you're going to see the big swollen eyes, you're going to see the face puffy, but it also goes into the mouth and the gums and the tongue. So it gets swollen. So why do they have a poor appetite? Well, they're probably biting their tongue, biting the insides of their cheeks, and they hurt. And because of that, their appetite really goes down. Because we are interstitial fluid, you're going to see weight gain. Definitely you'll see that. But unlike, would say, kidney failure, blood pressures are usually normal. Has nothing to do with that. And again, as I said, the urine is going to be 4+ protein or albumin. Remember, protein, albumin is the same thing. It's just a different word, but it means the same thing. And as I said, these kids, the neutrophils counts go really low, so they have neutropenia, as again, these are at a high risk for infection. I've said it, steroids will reduce that proteinuria and edema, but it's a two-edged sword here. Steroids are good and they work for that inflammation of the kidney. But remember, steroids also mask signs of infection. So you still need to monitor, is there sore throats, is there a cough, is there fevers, et cetera, et cetera. And because of all the protein loss, these children are hypoalbuminemia, which means low protein in the blood. Now, medications are taken and they go in the body and they go into the blood system and they hop on a little protein or an albumin. The rest that's left that doesn't get anywhere to go becomes free drug. Now, all the albumin or protein is being excreted. So you're going to see a lot of free drug in there. So chances of toxicity in this kid are extremely elevated, really, really high. Now, you think that with nephrotic syndrome and all this swelling, you just give some Lasix or a diuretic, furosemide. It doesn't work. It doesn't work with nephrotic syndrome. What they say with all of this swelling, they say to a diet low in salt, so you don't, retain more. And they say that unless you're having some sort of edema, like just a crisis of nephrotic syndrome, that you don't have to decrease fluids, but they say to monitor them closely. So what do parents do for these children at home and what these children should know? Well, these children need to really take control of monitoring their bodies, as simple as watching their weight every day, okay? Making sure they're keeping documentation. They start seeing weight gain, they know that something's going on and they're probably going to need steroids, get to the doctor. I also said their neutrophil counts are low, so they're at really bad risk for infections. So they're immunosuppressed, so no live vaccines, right? They're immunosuppressed. But also, what's the treatment for nephrotic syndrome or nephrosis? Steroids. Steroids also render you immunosuppressed, so no live vaccines. Because of the swelling, these kids need to be moving, they need to be up, they need to be positioned a lot. It moves the fluid around so the body can excrete it. And whenever you're talking about fluid and you're talking about edema, you need to be monitoring intake, output, and the daily weights. It's so important. That really looks at the fluid level in the body. Now, acute glomerulonephritis, or an infection of the glomerulars in the kidneys. That means there's swelling, something's going on there. Now, this is just like rheumatic fever that we talked about in cardiac. It is due to a strep infection. And what happens is all of a sudden these kids stop urinating. And that's usually what will bring them to the doctor. Like, what happened? My kid stopped urinating. Usually what you see is they've had a sore throat in the within 21 days. So how do we treat this? Well, again, we're going to be treating it by giving antibiotics and getting rid of that strep infection. And usually a couple of weeks later, the kid's fine. Now, Wilms tumor. This is a tumor on the kidney. It is usually found around ages 3 to 6, 7, African American and males. I've seen one in my career, right after the Haitian earthquake. Apparently, one of us doctors or nurses found this kid with this big lump in the abdomen. And they got the kid over to our hospital to give him treatment. Now, apparently this religious group got involved. They went to the airport, picked up this child, had his medical records, and were told bring him directly into the our hospital, into the ER. So I asked, so what's wrong? And they go, I don't know. Here's the records. Well, the records were in French. So I really had nothing to go by. The child only spoke French, and I don't speak, but parlez-vous français is about it, me with French. So not more I could do. So I had to do an assessment. I did my nursing assessment. I did vital signs. I started listening to his lungs. I was listening to his abdomen. And when I got to the left lower quadrant, all of a sudden I felt this big solid mass, a softball size. And for some reason, and I still don't know why, I knew it was a Wilms tumor. So immediately I put a note on the chart, and I notified the physician of what my thoughts were. I had no clue, but for some reason it came to my mind. What is the big thing with Wilms tumor? Well, this mass that's in there is extremely fragile, and pieces can break off and it can cause metastasis. So the biggest nursing care is to no touching the abdomen, leave it alone. They don't even do a biopsy before they do surgery on this because they don't want any little metastasis going in there. Now, what they do is they take this child, they check him over, they do either radiation, chemo, or both, and then they do surgery. So preoperatively, we leave that abdomen alone, and then postoperatively, we're going to be monitoring urine output, intake, right? Because it's the kidney, got to worry about fluids, and then of course your daily weights. And because that tumor and kidneys are on the back of the abdomen and they go through the front, making sure that this kid is moving his bowels like he should. Hydrocele is basically fluid around the testicle, and you're going to see a swollen scrotum. Usually it goes away within the first year. Sometimes if it's accompanied by pain and maybe incontinence in an older child, that's usually they're incontinent in the pain, they bring them in, they give them some antibiotics, and actually they do pretty well with it. Cryptorchidism. This is when the testicles don't get into the scrotal sac. You know, when you have a male born, first visit, in fact, every visit, you go in for the first year, the physician is going to go and check the testicles, make sure that they're in the proper place. Now, when you're checking for these testicles, if the room is warm, those testicles will sag down more. You'll have more chance to feel it, okay? Now, if it's cold, they suck up and you're not really going to feel them. So this is where you would put a child in a warmer room if you had that ability to do, so that we could check it better. These testicles don't like to be up in the abdomen. It's warm, and actually that warm actually cooks them, and it can cause these children to be sterile, you know, infertile. They're not going to be able to produce sperm, whether it's the one testicle or whether it's both, okay? So how do we treat these things? Well, sometimes we're going to give human growth injections. That can help. It has to do with sex type hormones, which will help the testicles form and descend. Or sometimes they have to do surgery and get them back in there. Now, as they get older, you'll be checking to see if the fertility has been affected, you know, sterility. Can they produce sperm that works, you know, to get a woman pregnant eventually in their life? And they must be doing frequent, like we do breast tests, women, men should be doing testicular tests to make sure that there's no tumors, there's higher chance for them. So after surgery, if we have to go in and take the testicle and bring it down, they need to have a scrotal support, holding that scrotum where it should be. Making sure, of course, the suture line is clean. We're talking down where you're stooling and urine. So, it really takes, they urinate, they stool, younger kid, change that diaper and clean it as quick as we can. As I said, always as I get older, checking that testicular self-exam. And remember, think about young children and they're worried about castration and they're worried about, the privacy, their body parts. They're really nervous about these things. So it's a big, big deal for these children. They think their penis is being cut off and they're really scared. So letting those children know what you're doing, why you're doing, and giving support is so important on this. Like I was just saying, 3 to 6, that's preschool. That's when they're masturbating. They're looking at body parts. They're, knowing that there's a difference between girls and boys, and I have a penis and you have a vagina, or whatever at home you call it. And they do, masturbate, hopefully in the privacy of their own place with nobody around, but it's just part of the growing up stuff with this, okay? So again, if there's surgery that has to be done, again, make sure the kid knows why you're doing it. It's not that you're punishing them for anything, because they always feel bad things or because they did something wrong. Just part of it. And so this is part of why we learn growth and development, right? So that we know that these kids are like it, and they really are. So let's go ahead. Any questions yet? We're good so far? Metabolic disorders. So metabolic disorders, we think of anything with hormones. We're talking about the thyroid gland, we're talking about the pituitary, adrenal glands, and we're talking about diabetes, right? So let's see what we can do with this. Now, look at all of the places that have to do with the endocrine system. So as I said, the hypothalamus, we're not going to go into that, but pituitary gland, the parathyroid, thyroid, your pancreas, adrenal glands. And then, of course, when you're talking pituitary gland, you have an anterior posterior lobe. Remember, the anterior lobe has to do with sex and if you're a boy or girl, that you're secreting those hormones. So what does it do? It puts chemical substance on these glands, puts it into the blood, and it does what it's supposed to do. And there is always hypo and hyper of whatever organ. We want to get it just right. So any problem with a child who's not getting the proper type of hormone, it's something that needs to be replaced. Now, a lot of these things can be detected just with all those developmental levels we look at. That a kid can lift his head up, can turn from his abdomen to back and back to front, and they can, knowing those things are telling me all about cognition. Think about, just for instance, the thyroid gland. If you don't have enough thyroid hormone, cognitively, you're going to be delayed. So, and that also goes with the musculoskeletal, the central nervous system. So these kids, when we see them behind, we start looking, what's wrong, what's happening. And there's a couple different things that we'll look for, and thyroid is one of those things. Now, how do you diagnose these things? Well, we do x-rays and we can do blood tests. At birth, they take that piece of, lab card, it's a long one, and on the end, there's 4 or 5 little circles, and they fill it up, the circles. And they're looking for PKU. It's a metabolic condition, it has to do with eating and absorption of food. You don't get enough, again, cognitively delayed, and it can result in mental retardation and delays. Of course, chromosomal studies, if we're ever worried, sometimes you have to do biopsies to figure out, and then just blood tests. I mean, if we're looking at the thyroid, what blood tests look at thyroid hormones? Well, your T3, your T4, your TSH. Then we can do an ultrasound. Look, is it enlarged? Is it small? And then these 24-hour urine looks at what's being produced in the body. And it's really a good telltale sign on many different vitamins and minerals and enzymes. And it does tell you if it's working well or overworking. Now, errors in metabolism. One of them is Tay-Sachs disease. Tay-Sachs disease is primary in the Jewish population, the Ashkenazi, probably the location of where they live. Because usually when you look at different things, that's what that usually means. And what happens is this. You know, we eat fats all the time. You know, that's just part of our diet. But what happens is you need an enzyme to digest that. And this is a deficiency of lysosomal beta hexoamidase. It's an enzyme. So you don't have the enzyme that can metabolize fat. So what happens to the fat? It goes and it attaches to nerve cells, and it doesn't allow synapsing, and it stops growth, it stops cognitive awareness, and these children will have physical and mental deterioration. And it is carried, it's an autosomal recessive trait. Now, at first, infants are born, they're really not getting high levels of fat. And then all of a sudden we start feeding them different things. So now all of a sudden what you're going to see is, remember, this fat goes and it goes around the nerves and it stops the nerves from being able to work the way they should. So all of a sudden you hold the kid by the hands, pull them up at 7 months, and their head lays back. They don't bring their head up when you pull them up. Okay, now there's a lag, something going on. Or they're not doing, you know, a voluntary palmar grasp. Something's wrong, needs to be looked at. What happens with Tay-Sachs disease is most of them die before 5 years old because of infection, or remember, fat is a nutrient we need, so that's malnutrition. There is no treatment, and it's just a palliative type of treatment that we give. What the signs and symptoms we show is what we'll do for them. Now let's talk about the thyroid gland. You know, the thyroid does a lot of things. And one of the things that we see, and sometimes there's no pre-warning, like why is a kid thyroid? But sometimes we can find this out at birth, which is actually the best time because there's going to be no delay in treatment. So how would we see that? What would the infant show us? Well, if you have hypothyroidism, are born with it, it's congenital. What happens is these infants will not pass a stool for the first 24 to 36 hours. There's a couple of other things, but hypothyroidism is one of the things we'll check for. Now, thyroid gland, it works with metabolism, and again, it's good for growth and cognition, okay? So we found out that they're not having a stool. So one of the things we're going to check for is thyroid. What are we going to do? Well, T3, T4, TSH. If they come back with weird things, we're going to do an ultrasound. We're going to look at it. If we find out it's under functioning, what are we going to do? We're going to give a thyroid medication. Levothyroxine or Synthroid is one of the most popular that they get. And it replaces it, and the kid grows and be's absolutely normal. So what do you see if you didn't get that at birth? Okay, maybe it's, you know, down the line. And now all of a sudden this kid is really tired, sluggish. Their tongue becomes big. And now they have these noisy respirations because that tongue's so big, it's almost like a snoring that they start to do. Now, adults, you'll see this too. You'll see this dry skin. You'll see kids, their hair is thin. And also it's dry, it's brittle, constipation. And there's this cold intolerance. So that is similar. And then growth is always children. But all the things you see in adults, you actually see in children. So the skin is dry, they're not sweating. Their hands and feet are cold and they're floppy. Remember, thyroid hormone helps with muscle development, central nervous system, motor, and cognition. So you'll see them floppy. That constipation you'll see, the hair as it grows will be that dry and brittle. Now, if it's treated, these kids turn around, they catch up, they'll do great. But if, remember, that first year of life, think about it, they triple their birth weight. They go from not lifting a head to taking their first unassisted walking. They'll take a step. So it's amazing what they do. Now, if we don't give this replacement, these children will have irreversible mental retardation and physical disabilities. So there's a lot of hints, a lot of clues, and this is why we learned so much about growth and development, right? Now, as the kid gets older, there's something called this lymphocytic thyroiditis. It's an immune thyroid, hyperthyroidism. It is, it's an immune. My daughter-in-law has Hashimoto's. And what we do with this is this disease, you need to give replacements. It's usually 2 different medications that are required with this. It needs chronic to go and get your levels checked to make sure that they're getting enough. And again, if you're not getting enough thyroid hormone, what else can I tell you? Central nervous system problems, and you're going to see those cognition and movement and muscles and physical and mental delays. So it needs that thyroid in order to grow and to be healthy. Today, the screening test for hypothyroidism is mandatory, and we do that at birth before they go home. How do we treat it? Well, thyroid hormone should be given in the morning, same time every day. It's because it gives you almost like a boost. Because remember, you're lethargic without the hormone. You give the hormone, there's actually this little, pick me up. It's not like, giving yourself something to speed you up thing, but it does. It helps your body work better and think better. Now, giving it in the morning, we'll be giving this synthetic over-the-counter with a prescription, of course, medication every morning, same time, and be monitoring those serum levels. Remember, kids grow pretty quick. Making sure that they're getting the proper dosages is really important because, therapy on these children that are on low levels of hypothyroidism, you're going to see these delays, but you can catch them up if you catch it in time. They're going to be going through, now, these kids that didn't get it at birth that we catch later on, you're going to see them go through some insomnia and aggressiveness initially, but then they'll catch up because remember, this cognition and physical movement are all going to be changing and catching up. Now, once you're on thyroid hormones, you're on thyroid hormones for life. So what happens if, let's say, you doubled your dose? Could happen. Or what's to say if, the dose was too much? And so now you are in basically a hyperthyroid sort of state. Well, everything speeds up. Because remember I said without it, you're down, you're tired, you're lethargic, you sleep a lot. And your mental decline. Well, if you're talking about too much, your heart rate's up, your chest is tight, you're dyspneic, you're irritable, everything speed up, weight loss, and then you'll have sweating. And then again, not enough, this hypothyroid, you're tired, you're sleepy, and then of course, constipation, cold intolerance, all of those things. So parents need to be taught so they understand what's going on with their child. This is hereditary. It could be caused from a head injury. Think about a head injury in the pituitary gland. If it's, in there with swelling, it can affect it to be work more or work less. So that can cause it. When you're talking about the posterior pituitary, you're talking about urine. You're talking about the hormone that causes your kidneys to urinate. If it's too much, you're urinating a lot and you're thirsty. And that is called diabetes insipidus. Okay, that's part of pituitary gland. So these children need something to stop that, because it's urine. You drink and it's coming. I mean, it's massive amount of urine and thirsty. So we give vasopressin. And vasopressin is something that is anti-diuretic or against urinating. So it's working when the urinary output decreases, okay? So here is a great chart, diabetes insipidus, and then the opposite of diabetes insipidus is when you don't urinate at all or minimally. And that's called syndrome of inappropriate antidiuretic hormone, SIADH. So syndrome of inappropriate antidiuretic. So anti-peeing, that's what I call it. Anti-diuresis. Anti means I'm not urinating. So if you're not urinating, you're holding it. So what would you see? Well, the kid's going to be swollen. This kid's going to be gaining weight. And these children are going to need something to stop this edema and this urinary output to start. So these children will be watched their daily weights, their intake, and their output. So that is the posterior pituitary gland. And as I said, diabetes insipidus is urinating and drinking. So one, you urinate a lot, and one, you barely urinate. So either getting rid of it or you're keeping it and swelling up. Now, the anterior pituitary gland has all about growth. So you could be short, so you have not enough pituitary hormone being secreted, and you could call that dwarfism. These are your little midgets, right? Or it could be these children who are tall and big. If it's not treated, some of these kids, gigantism it's called, can be 8 foot tall, and many times that's due to a tumor. Now, let's talk about two other things. Parathyroid is not a thyroid gland. It is right next to it in the neck, but it's not secreting thyroid hormone. What it does, it monitors calcium and phosphorus. Now, when you think of calcium, always think about muscle tone. So if you don't have enough as an hypoparathyroidism, you don't have enough calcium. You don't have enough muscle control. So this is going to be that weak, floppy child. And this one, because of that, it can go into laryngospasm because there's no muscle to hold it open so you don't breathe, okay? Now, too much calcium causes spasms and tetany in these children, and it's very, very painful. So again, you need to get that calcium level where it needs to be, monitoring the calcium levels in the blood. So we have quite a few slides on diabetes mellitus. Now, if you lose it, you don't understand it, please stop me. So let's talk about what is diabetes mellitus. Well, children get type 1, all right? Older children, adolescents, can be type 2, usually due to being overweight. But what is type 1 diabetes? Because once they're type 1 for life. They don't change. They don't grow out of this, okay? They will be type 1 for life. What happens is the body, it's an autoimmune where the pancreas stops secreting or slows way down the production of insulin. And what is insulin? Insulin's an enzyme that goes in and makes sugar or carbohydrates into a form the body can use. Now, what happens if I don't get any sugar? My body's not producing insulin. My body's not eating sugar. It can't use it. Well, if it's not using it, my blood sugar levels are going to be very high. The highest one I've ever seen in my life was 1,108. This kid made it out. This kid, we, learned a big lesson, everybody did, but it's the highest I've ever seen. Kid came in pale, lethargic, bent over, and you could smell sugar in the air. It was that much. All right, so you've got a kid who now is not eating sugar, and the body's hungry, and it says, okay, what am I going to do now? How am I going to get my belly full? I need to eat. I'm hungry. The sugar, I can't use it. Well, it starts eating fats and starts eating proteins. Now, when the body starts eating the fats and proteins, the byproduct is called ketones. And that's why you see ketones in the urine, okay? So you have really high blood sugars because you can't use the sugar, but you're eating something, you're satisfying the body's nutrition needs by having fat and protein, but the byproduct is going to be with ketones. So ketonuria or ketonemia, you're going to see 4+ ketones in the urine. You're going to see 4+ glucose in the urine. So we need to take this situation and turn it around because children need carbohydrates. Again, nutrition in order to grow and, to mature their minds and their bodies. Now, diabetes mellitus is, about sugar, but because of this sugar, there are some really long-term complications with it. Having an infant or a younger child, I mean, the youngest I saw diagnosed was like 2.5-year-old little girl, recent weight loss, and you could actually smell the glucose, the sugar in her breath when she came in. But a lot of times you see adolescents coming in, and when you start seeing them coming in a couple times a year, we know how dangerous that is. So I try to sit down and have a one-to-one talk on them and tell them what the outcomes for not managing their blood sugars can do to their bodies. Well, young adolescent girls love their eyes. They love to put on eye makeup, wear eyelashes, get their eyebrows done. And what if I said, well, I understand how hard it is to monitor your blood sugars and eat right. I said, but if you don't, you can become blind, because eyes are so important to them. Sometimes it makes a difference and I don't see them again for a while. And that makes me happy. Now, I had a 21-year-old EMT who worked with me quite a bit. Good looking guy, type 1 diabetic. He had been for about 10 years now. And I kept seeing him coming in, to the triage where I worked a lot. And he came in this one day with this big piece of cake. And I went, Danny, what are you doing? He said, well, I'll just give myself some more insulin. It will be okay. And I said, Danny, you know how dangerous that is. Do you know what the long-term complications of doing that is? I says, there are what we call neuropathies, or your nerves don't work as well. I says, one of the nerves that it can affect is the nerves in your penis, and you're not going to be able to perform. Now, telling a 21-year-old person that, it really made sense to him. And it really struck a nerve. And, like 5 years later, we're working again. He worked there a long time with me, came up and hugged me. And he said, Betty, I want to thank you because you really made a difference. And what you said to me, I didn't get it until you said that. I said, yeah, I'm sorry. It was a really hard way to put it, but I care about you. And he was like, no, thank you. Because sometimes in children, adolescents, and 21, he's a grown man, sometimes they have to hear it for what it is. And if it helps, it helps. Now, what are other things we see? Well, as you get older, that neuropathy, the numbness in the feet, you don't feel yourself stepping on things, you get cuts, and it can cause a lot of problems with circulation and healing, and a lot of amputations can be done with people with diabetes. There are classifications of diabetes. Type 1 is insulin dependent. Type 2, you're still producing some insulin, but it's not enough. So there's different medications that we give to try to make the body produce what it can. And then gestational, when you become pregnant, sometimes the body says, I don't know what to do with these sugars. And many of them, now in pregnancy, you cannot take oral anti-diabetic pills. You can't. You have to take insulin when you are pregnant, okay? That's something. Now, once the baby's born, they're usually fine, but you have to be careful. They can get diabetic, years later. It's like a preskewer. Now, there are some genetic things, and this is something you need to know. What chromosomes can cause diabetes? And those are 6, 7, 12, and 20. They can cause diabetes. So what do you see? Well, fasting blood sugars are going to be 126, and you are going to see that autoimmune that I told you, that Hashimoto's, or you're going to see type 2, which is resistance to insulin. Usually they're on oral anti-hypoglycemics, glycemic medication, and it basically tries to make the insulin be produced. Whatever there, it tries to force it to work better. Now, what causes, blood sugar issues and problems? Well, the young kids, remember, so a lot of things can cause it. I mean, just being sick, stress, school, all of those things. Think about those young diabetics, 11 to 13 years old. These children these children are going through what at that age? That pre-adolescent growth spurt, remember? They're growing like crazy, and they're doing all this hormone stuff going on because, and their insulin needs are going to be a little bit different. So a lot of these things can cause issues with their diabetes. Now, with diabetes insipidus, which has nothing to do with blood sugar, you have polyuria and polydipsia, okay? They're not hungry. They're getting sugars. They're good. But when you're talking about diabetes, it's that triad, it's 3. Because they're not getting their sugar, they can't digest it. There are polyphagia, polyuria, polydipsia, which is polyphagia, I'm hungry, hungry, hungry. Polyuria, peeing, peeing, urinating, urinating. And polydipsia, drinking, 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 drinking. Now, symptoms are come up quick, and you're going to see things go on with these kids. As I said, these kids come into the ER when they are with diabetes. out of control. They are pale, they're leaning over, they're weak, they can hardly hold their heads up. Sometimes they're nauseous and they're vomiting. And you'll see their skin, you can actually see how dry it is. And some vaginal yeast infections you can see because of diabetes in those adolescent children. Now, what do you see? Hyperglycemia. Yeah, of course, they're not eating and digesting carbohydrates so the body can use it. So you're going to see elevated blood sugars. Again, they're eating protein and fat, and you're going to see that proteinuria. And that lack of glucose, the body's like, hey, you need to eat. So they're eating, they're drinking, and they're urinating. It's 1, 2, 3, over and over and over again. Now, after the initial diagnosis, the child is stabilized with insulin and they look better. They come in looking horrible. 1 hour later, these kids are pink and alert and they're back to being themselves, okay? Now, at that point, because they have their insulin, they're eating their carbohydrates, they feel good. But this is only for a short time because remember, their glucose levels are going to be going up and down according to food eating, stress, and everything. So again, monitor it closely. That is called the honeymoon period of diabetes. How do we test for diabetes? Well, simple blood sugars, right? Absolutely. But fasting. And again, fasting, you're going to see greater than 126, and you're going to see it on 2 separate occasions. I mean, I used to always say, yeah, my cholesterol was up because I had some ice cream last night. Let's do it another day. Well, yeah, my cholesterol level was up another day with no ice cream. But same thing with sugar. Yeah, I had a cake last night, so it must be that the cake. So making sure it's 2 separate times to give that diagnosis. But once we do that, we're going to be looking at glucose tolerance tests. That's what having diabetes and being pregnant, they love giving that glucose tolerance test. I know a lot of pregnant women want to vomit with that sweet taste, but it's something important to really look at. You'll see elevated blood sugars. And then the other blood test that you see is a glycosated hemoglobin A1C. And that measures the blood sugars for the last 3 to 4 months. So are they compliant with the treatment, or as you are diagnosing them, is it that they're, are they diabetic? Let's look at those blood sugars from the last 3 to 4 months. Diabetic ketoacidosis is when there's not enough insulin for whatever reason. It's a child, not testing blood sugars, not eating right, what's going on. All of those things can cause it. And we know if they're not having their carbohydrates eating, there's not enough insulin, they go to their body and say, okay, fats and proteins, I'm hungry, and let me start digesting you. So that's how you get into diabetic ketoacidosis. Again, you're going to see that ketones in the urine, you're going to see glucose in the urine, and you're going to be dehydrated also. The fruity odor to the breath. Let me describe it to you because this actually is spot on what it smells like. Take a nice juicy peach, put it in a tight Tupperware container and put it in the refrigerator. Pull it out a month later. Open the top. That rotten sweet of a peach smells like DKA, that fruity breath, exactly like that. There's, it's the best way to describe it. It's really, really sugary. Now, as I said, they're nauseous, they might vomit, and because they're not getting sugar to the brain, there's going to be some altered level of consciousness. And we know that it could be a mild case, severe case, depending on how long they've been sitting with it. So our goal on diabetes is to try to keep blood sugars where they need to be and to give insulin as needed. You know, these kids need to be kids. I mean, this 3-year-old little girl that I found that was sent to me, you know, we want her still to be a kid. But these children need to know what they can do, what they can eat, and, you know, they need to make sure that they know what can happen if they're not, you know, doing the proper things. You know, teaching parents, teaching children is important. Remember, insulin and taking care of it is expensive. You know, those test strips and those machines, yeah, they give you free machines like crazy, but those test strips are very expensive. And many parents will say, oh, you can only do it once a day. I don't have money for it. Those pens could be $300-400 for each one, and you may need 2 or 3 a month, and that's after insurance. So remembering those things. Another thing is there's beef and pork insulins. Now, what if you are vegetarian? Or what if you are one of those religions that don't eat pork? You know, there are some Jamaicans, my husband was telling me, some of them don't eat pork. I'm like, you don't eat jerk pork? Oh my goodness. But anyway, if you gave them insulin with pork in it, you're going against their beliefs. So being aware of that and letting those family know those things. So children with diabetes, remember, children still grow and they're growing really, really quick. So growth is not steady because sugar goes up and down. We know that children, they're going to grow and then they're going to stop and then they're going to grow. It's like, you know, that stair step thing, as I call it. Infants and toddlers, hydration, giving them enough fluids. Are they getting enough in them? Children have irregular activity and eating problems. They don't eat, you know, the same things. They don't want to eat. They don't eat. Some days they eat like crazy. Some days they don't want to eat at all. This is kids, right? Some days they're active. Some days they're not. Children are all over the place. School-age children can grieve over this diagnosis. Like, I have to worry about my diet forever. You know, it can be like that. Sometimes, oh, I'm diabetic, poor me. You know, they want special treatments. I mean, that can happen. And remember, when they go through puberty, pre-adolescent growth spurts, all of that is really messes with diabetes and the insulin and the blood sugars. So it needs to be watched really closely. And we know adolescents want to do what they want to do. And sometimes with diabetes, you know, they are not taking care of it the way they should. So how do we treat? Well, a good diet, giving insulin, and as they should, and then of course exercises help. So what are we going to teach parents and what are we going to teach children? Well, they need to understand diabetes and how to treat it and to be successful with that. So what's the pancreas and insulin and what does it do? They need to know how to do their own little blood glucoses. They need to know what are the combinations of foods that they should eat and what those foods can be. You know, how do you take care of insulin? Is it put in the refrigerator? Is it not? And of course, exercise. How much is too little? How much is too much? Remember about that peripheral neuropathy, you know, decrease in nerve and sensations? Be careful with skin and foot care. Infections causes blood sugars to go all over the place, and any sort of stress, emotional upset. Checking urine, is there ketones? Is there blood sugar in there? And then of course, glucose insulin imbalances. Are they eating? What are they eating? Is the insulin enough or is it too much? And then travel. When you travel, taking care of your insulin, making sure that it's properly managed. If it has to be cold, do we have it somehow packed that way? Also, do we have those snacks in case of hypoglycemia, taking care of ourselves? And then, of course, follow-up care, making sure that they go to the doctor when they're are ordered to go and when their appointments are. And remember, illness causes issues, and if they're having surgery, they need to know so they can manage your blood sugar, you know, the best we can. Nutrition, nutrition, nutrition. You know, nutrition must be managed as best as we can. If you have nutrition, your mind and body are going to grow and you're going to be healthy. So important that these children know what they can have and what they can't have. Remember, what I eat is different from what you eat. It could be cultural, it could be, you know, my age, sex, weight, all of these things. It could be how much I can afford. You know, can I not afford to eat, you know, certain things? All of these things play a role in how to eat. And the caloric intake depends on your body size. You know, if you weigh 50 pounds, it's going to be different than a 150-pound person. And the one thing about carbohydrates, you should have the complex carbohydrates because these actually go into the system slowly and the body has a chance to, you know, use that with the insulin given, okay? And one thing about dietary fiber, now soluble, I'm not talking bran flakes, not that. I'm talking about raw fruits, raw vegetables. These are so great. With eating them, it reduces blood glucose, serum cholesterol, and because your glucose levels are lower, you need less insulin. So fiber slows the rate of absorption of sugar. So you get rid of it before you use it. So it's a good inclusion into a diet. So a lot of these labels, have you ever read some labels on, you know, food products and it goes dietary, or one of those things? Well, when you look at it, the sugar and the fat contents are like really high. So be very careful to read labels. Giving insulin, making sure that the parent and the child knows how. Remember, insulin is a subcutaneous injection. It's either, you know, straight in if you have enough subcutaneous, or maybe you have to do it 45 degree. And, you know, you think this is crazy to put in here, but you don't drink insulin. The gastric acid will absorb it, because I'm sure some patients have tried. And like I just said, I'm giving the injections. They say at age 7, children can start doing it themselves. They really need to start participating in their own care. And again, making sure that we move it around, that we only put injections in good, healthy skin, okay? And if, you know, you inject the areas where, let's say you're gonna go ride a bike and you need to give insulin. If you put it in the leg, you're pedaling. What are you doing to that insulin? You're making it go into that body quicker. So thinking of that sort of things. I mean, have you thought about that? I mean, it's a simple thing, but you know, many patients don't know that. We give insulin in a lot of different places. Today we've got a lot of those pens, but it is clear before cloudy, and pulling it up and helping and teaching our patients and family this is very important. Now, one of the things that we need to teach is, if I take regular insulin, when is it going to start working? As in, if it's regular insulin, I've covered a blood sugar and it was before breakfast, and let's say the patient's in the hospital with me, and I notice 45 minutes later, there is no tray. Breakfast hasn't come yet. That patient is going to become hypoglycemic. We need to get them something. A glass of milk is good. And, you know, graham crackers is good, something little to wait for the tray so they don't go hypoglycemic. And a great choice for children is a pump. That insulin pump is a really good type of choice for those children who can manage it. So insulin shock is blood sugar is too low. We know that the blood sugar goes low, there's too much insulin, and it could be because of many different reasons. It could be exercise, you didn't eat enough, or maybe you gave too much insulin and didn't know better. Children are more prone to insulin reactions than adults. And why is that? Well, you remember, children are still growing. Activities are what we call irregular. They may get up and go and run, or they may not even move, and every day is all different. Now, what do you see when you see hypoglycemia? Well, these children get irritable. They start not acting correctly. They say behave poorly. They get pale. They're hungry. They're weak. They're sweaty. They're jittery. They're shaky. Okay, because they want sugar. And you should have these patients have always something that they can eat. Now, they do have products you can buy at the pharmacy, but they're always expensive. You know, they have this little sugar paste that you can put in your mouth. But what about some lifesavers? I mean, those are always easy. Or go to a restaurant, they haven't served the food yet, but what's sitting there? Sugar packets, right? Something. If you're going down that blood sugar, there's always something. Now, that's when a patient's alert. Now, what if they aren't? They're comatose. They're unconscious. Well, that's when you give glucagon. It's an injection, and that can get the blood sugar up quick. Now, Somogy phenomenon is what we call rebound hyperglycemia. So what happens is the blood glucose levels are lowered to a point where all of a sudden the body says, let me give some epinephrine, some cortisol. Remember, steroids affect blood sugars, and glucagon. Again, sugar. So all of a sudden, glucose is relieved from the muscles, and poof, all of those glucoses go up. So Somogy is when the body tries to overcompensate and secretes whatever sugar they have. You know, you just think about the liver, right? Part of it, glucagon. So it's, they say more Somogy phenomenon, has to do with that chronic insulin use there. Now, dawn phenomenon is different from Somogy, but it's early morning elevations of blood sugar, and they have not had hypoglycemia before. It's like early in the morning, their blood sugars are elevated. So that's the difference between Somogy and your dawn. Now, diabetes, what do we think causes it? Thought that, okay, it could be due to obesity. And I mentioned that about being type 2 when you're an adolescent. It could be because you're not active, you're not up and moving, you're on video games all day long or whatever. And of course, a fat-rich or lipid-rich diet, and that causes insulin resistance. So what is our focus? Diet and exercise. And of course, the insulin or oral hypoglycemic medications, all of that can help with it. So that was a lot of information. Did you follow me along there? So we're going to do the Kahoots now. Again, hitting on those concepts that were pretty big. Let's see how you all do there. Any questions, anybody? I haven't put anybody to sleep yet. I was trying. No, I'm teasing you. Try to give you enough to keep you awake and give it to you in a manner that you can get it and understand it. Again, if you don't understand, please stop me. I am never upset. That won't bother me at all. And I've always had this saying that another nurse taught me many years ago. There is no stupid question if you don't know the answer. Okay?
Professor Bogart, did you get my messages in the chat?
I hadn't looked. Let me look for you.
Thank you.
Okay, not a problem. I understand. I know that's going on right now.
I've literally been booted from the Zoom more times than I can count currently.
So you're going to have a list of your name about 12 times. I'll see that when I'm looking at the report. It's okay.
It just keeps because it kicks our Wi-Fi every time the power goes out. And so it's kicking me out, and then I have to wait for the router to restart before I can join back in.
Yes, it's like what happens to me sometimes. Boof, I'm gone and there's no reason. But I'm home and my internet here is pretty good. A newborn scrotum is enlarged and swollen on one side. Why? We can call that a hydrocele, right? Could be one side unilateral or it can be bilateral.
I was still trying to get into it, Ms. Bogart.
What did you want to say?
I needed the pin to get in.
You want the pin? Okay, let me get it for you. Hold on, I gotta move this over here. Pin 1372998. You got it? Jeffrey, did you get it? Shake your head. 1372998. Let's keep going.
Okay, yeah, I got it.
Providing information to parents of a child born with bilateral cryptorchidism. What information is important to include? Well, what is cryptorchidism? Do you remember that? Remember, it's something to do with the testicles. So what do you know about the testicles? So sometimes there is this thing, this inguinal hernia, which goes out and actually it blocks and holds those testicles up. And that's why sometimes you see that inguinal hernia there. Remember, those testicles don't like to be in that warm abdomen. Multi. The nurse caring for a child with nephrotic syndrome is alert to which classic signs of this disorder? Remember, nephrotic syndrome or nephrosis has nothing to do with kidney failure. The kidneys are still working. But the kidneys say, I don't like you protein, let me get rid of you. And that causes generalized edema. So a lot of times they come in, you see it around their eyes and you see their tongue pretty big. Then they're tired and proteinuria. And it's—
Was this a select all that apply?
This was a select all, yeah. Hypoalbuminemia, it is not hyper. There are quite a few select alls. It's something to help you get into practice with them because I know many students struggle with them. A multi. Genitourinary surgery is especially stressful for preschool children. What factors lend to this stress? Now, these are your ages 3 to 5. Remember, they're really curious now, and they're starting to know penises and vaginas, and there's differences, and they're starting this masturbating, but they're also afraid of castration, and they're also thinking that, oh, I did something wrong, I'm being punished. This is all about those preschoolers. Another multi. What special considerations are related to long-term prednisone therapy in preschoolers? So what do you know about prednisone? You know, the only thing that I don't think I mentioned is prednisone can cause elevated blood sugars, one of the things. But it's also, you're at risk for infections. Because you're immunosuppressed, you can't take an immunization, so you will have delayed of them. Has nothing to do with nutrition. Actually, it gets them more hungry. And The sex organs is all about the pituitary glands. It's not to do with prednisone or adrenal glands. To prevent urinary tract infection, which is the best beverage for the nurse to recommend to keep urine acidic. I mean, I think everybody would say cranberry. Well, cranberry isn't an answer. Which one is it? Apple juice. Very good. You remembered. I told you. When weighing the diaper and subtracting the weight of a dry diaper, the nurse records 30 grams and documents how many mLs in the output. So you have a 30-gram diaper, and when it's dirty, it weighed 60. So the difference is 30 grams. When you figure it out, it's 1 gram equals 1 ml. So it is 30 mLs, okay? Each gram of weight is 1 ml of urine. Even if there's stool there, it's still 1 ml. Another strategies to prevent a reoccurrence of urinary tract infections in a child. And what are you going to do to help decrease the amount of UTIs? It's no bubble bath. Good job. You got it perfect. When do you correct the hypospadias of a newborn? Remember, that's when the urethra doesn't go to the tip of the penis. The hypospadias is in the ventral part or underneath. Epispadias is the dorsal or the top of the penis. And you want to do it before they're potty trained. And that's about 18 months. Very good. What is an initial sign of nephrosis the nurse might know in a child? Nephrotic syndrome, nephrosis, same thing. You know, you're talking kidneys. What do kidneys do? And that's the way you need to think when you look at questions. And then you can find the answer easy. And it's periorbital edema. Remember, nephrosis, kidneys, you're talking urine, you're talking about fluid balance. So that one's periorbital edema. Foreskin is retracted and very tight on the shaft of the penis, unable to return it over the head of the penis. What are you going to do? Just got done giving a nice bath, weighing the child, dressing them up cute for mommy. And that penis, that foreskin is stuck down. What are you going to do? You're going to call the charge nurse right now. Now, if you put a warm compress on it, actually you're swelling it more. You know what they actually do? They put cool water on it because it constricts it, and sometimes they're able to pull it. But that's a physician does. And we're not going to do it for a long time because actually you can get frostbite with like ice if you try to do that. Plus it's cold. Which urinary diversion procedure is the least damaging to the body image of an adolescent? Which means their urine doesn't come out of the body normally. They need it, you know, to be placed somewhere else. You know, you have these colostomies for stool. Like, what are you going to do for this adolescent? Now, the urostomy is a bag sitting on the belly. So is the nephrostomy. So is the suprapubic. An ileal conduit means they've stuck the ureter into the intestines. So now we're having the urine coming out of the rectum. That means there's nothing on the outside of the body, and that helps with body image on adolescent. What foods does a nurse recommend the child with acute glomerulonephritis avoid to prevent hyperkalemia? What is hyperkalemia? That's too much potassium. So which one of these has too much potassium? And that is bananas. Bananas orange juice, high in potassium. Which physical assessment will the nurse omit when caring for a 2-year-old diagnosed with Wilms tumor? So remember, this tumor is very fragile and you can't touch it. So no palpating the abdomen. You could cause metastasis just by, massaging it and palpating. What is the probable cause of acute glomerulonephritis? Nephritis, inflammation of the kidneys. Just like rheumatic fever, it has to do with a strep throat. Rheumatic fever, glomerulonephritis could be caused by a sore throat. So what are you going to ask if you see a child elevated blood pressure and not urinating? You're going to say, have you been sick lately? And it's probably the strep throat. Treat it with antibiotics. Another multi. What will the nurse caring for a newborn with exstrophy of a bladder include in the care plan? How do you take care of exstrophy of bladder? It means the bladder born on the outside of the abdomen. They're going to be on their back. You are going to be putting skin, protect the skin, but it's not a shield we'll be protecting that bladder with. It's some sort of moist material to protect them from infection. It's not per se the word there of shield. It's just to protect the integrity of the tissue. A child has a burn evidenced by pink skin and blistering and is in pain and crying. What type of burn is this? When we look at burns, we want to know, are they in pain or are they not? Because if they're not in pain and you see a burn, you know that that is a higher level or degree of a burn. Now, pink skin, blistering, and pain, that's the 2nd degree, and it's superficial because there's still pain. A child's brought to the ER with burns on the face and chest. What is the nurse's first priority? What are you concerned about with burns on the face and the chest? We're worried about airway because they could have inhaled it. You never know. Always be careful of the respiratory. What should the nurse stress to the mother of a child with impetigo? Now, my grandson came over here and my daughter said the kid was itching a bug bite and he itched too much at night and look what he did to himself. This is caused by a scratch that gets staph in it, and it's extremely contagious and it spreads. He literally behind his back from his knee bend down to mid calf was this big, scabby, juicy sore. How do we treat this? With both topical and oral antibiotics. And it took a week for it to heal up. It was pretty bad. Documenting the description of a skin assessment, what term can be used for an elevated fluid-filled blister? Now you need to know the descriptions of these, okay? You need to know what these are. You're going to see them again. And that is called a vesicle, okay? That's a vesicle. another multi. Which factors activate the herpes simplex virus type 1? You know, I call that a cold sore. So remember, any infection is always stress, absolutely. Fever, you get sick, it comes out. Sun, and remember, hormonal too. So menses, all of the above. Only use prescribed amount of ointment to the skin of a 2-month-old infant. How is the infant skin different from an adult? Remember, adults and children, there's a lot of things to remember when we're caring for them. Using topical ointments and stuff, you must be extremely careful because they absorb it so quickly. You know, if you put on a steroid ointment and overuse it every single time, you could put this child into like a Cushing syndrome from all the steroids absorption because they absorb it really fast. Football players are taking oral gracefulin for tinea pedis. What should the school nurse caution them to avoid? That's athlete's feet. Pedis or pedis, pedis, tinea. This is an antifungal medication. And if we're not careful, if they drink alcohol, they are going to be uncontrollably vomiting. I describe it as you have an alcoholic and you give them antabuse, because if they drink, they'll vomit, okay? But not just vomit, it is just constant and it lasts a long time. Well, oral antifungals are the same thing. You take a drink and you're going to be vomiting and vomiting and vomiting. It's just like taking that anti-abuse medicine. What must be started before a 17-year-old girl starts a protocol of Accutane for her acne? This is a black box notification precaution on these children. And, you know, they've tried everything else before they tried Accutane because there are really big concerns. Now, they have to sign a thing that every time they go in and get a prescription, they will not become pregnant. And they're placed on oral contraceptives just to be sure, because it causes really severe deformities of babies. So they do not want these children getting pregnant. Which allergy would contraindicate the use of silvadazine, which is Silvadene for burns? It's a great ointment, this white stuff cream, and it alleviates pain, and it really helps with healing pretty quickly. And you know, the other one, besides this, is also furosemide. Lasix sulfa, which is Bactrim, Septra, antibiotics, and furosemide and the silver. All of those things, they are interrelated allergy. What is the accurate nursing response to a mother who asks, how can I get rid of the baby's cradle cap? The cradle cap is when they're born and they've got this white flaky on their head, and it annoys the mother. They want the little girl to have a cute little ribbon and not have all this white stuff. Well, it's dry type skin. So they put baby oil on it, leave it overnight and wash it out in the morning, and then use a soft bristle brush and brush it out. Soft bristle brush, bristle on their brush, okay? Nothing hard. We don't want to hurt that baby's head. A child is experiencing intense itching in the axilla between the fingers, and it's worse at night. What could this be? Intense itching in the axilla between the fingers, and it's worse at night. And this is scabies. And scabies is contagious. And once we hear as nurses the child has scabies, many nurses put on yellow gowns and even put their heads in these caps because they don't want to get it. An adolescent presents with a butterfly rash on their face. What diagnosis does the nurse maybe suspect here? And that is lupus, and that's what you see. And lupus is when the body attacks organs of their own body. The body doesn't like the organs and attacks them. Another multi. The nurse speaking to junior high school students informs them that acne can be exacerbated by which drugs? Phenobarb, steroids, and phenytoin are all the ones that it can exasperate. They actually sometimes put these children on oral contraceptives. It's the hormone that actually, turns it around and clears up the acne. Dilantin or phenytoin, you can see them 6-year-old kids and you can see their acne. And you also see that, gingival hypoplasia, those big, thick red gums and that acne. And you're like, this kid, yes, has seizures or on phenytoin. Another multi. Which food sources are high in soluble fiber? Raw fruits, raw vegetables, and beans. Bran cereal is not soluble, okay? There is a difference. I expressed that when I was teaching it, but it's raw fruits, raw vegetables, and beans. Another multi. Which symptoms does a nurse recognize as signs of an overdose of levothyroxine, Synthroid, which is used for hypothyroidism? Remember, hypothyroidism, you're down, you're sleepy, you're lethargic, cold intolerance, dry skin, thin, brittle hair, okay? You take too much of it, all of a sudden your heart rate's up, blood pressure's up, you have tightness in your chest, you can't breathe, you're irritable, and you are tachycardic. It's also called, it's type of a thyroid storm. The glycosated hemoglobin A1C test is a test that can evaluate average glucose levels over a period of blank to blank. It can show if you have the disease or if you're compliant with treatment. And it's 3 to 4 months. We can see how are those glucoses going. What occurs as a result of an inadequate secretion of insulin? So if you don't have enough insulin in the body, that means you're not using sugar, right? So then what occurs? So you see how I'm thinking about this, how I'm answering these questions? That is increased fat and leads to ketonuria, and you will see high ketones in the urine. Child receives a combination of regular and NPH insulin at 8 o'clock. And at 8:45, the breakfast trays have not arrived. What are you going to do about that? Anything? we're going to give them something because they're going to go hypoglycemic if we don't. Give them some graham crackers, give them some milk. A child with diabetes is brought to the ER. He's flushed, drowsy, and his skin is dry. This child is experiencing what? And that's just ketoacidosis when they're, that flushed and drowsy and they're dry. 4-month-old infant's lethargic, sleeps 18 hours a day, and snores. Signs are characteristic of what? Noisy respirations. It's that big, thick tongue. And that is all about the thyroid. Remember, thyroid, you don't have enough, you don't have energy, you gain weight, and you're just lethargic. And you get those noisy respirations. A child with type 1 diabetes mellitus has hyperglycemia, diaphoresis, and headaches in the morning. What is that? Hyperglycemia and diaphoresis in the morning. What is that? And that is your Samoji. After a closed head injury, the child begins to excrete copious urine and a drop in BP. What does the nurse suspect? Remember, head injuries causes swelling in the brain. And what would cause this urine to just start putting out urine like crazy? It can cause diabetes insipidus. Good job. Yes. What does the nurse instruct a 12-year-old to do when teaching how to administer insulin? So we know it's sub-Q, and we're going to go 90 degrees and give it in good healthy tissue, and we're going to move the sites. Why does the nurse instruct an 11-year-old diabetic child to use the side of the finger for blood testing? Why not right there in the middle? Is that because they can't text on their phone and use their video games and play games? Why? It has fewer nerve endings, and actually it bleeds better on the side. What is the function of an insulin pump? Like, why do we need an insulin pump? It's a continuous infusion of insulin, and it's one needle you stick in and put a dressing on it, and it's only one stick, and you can leave it in for several days. A multi-select. What does the nurse remind the adolescents with diabetes that soluble fiber in the diet can reduce? Soluble fiber reduces what in the diet? Again, the word soluble fiber. That means raw fruits, raw vegetables, right? So it can do all of these, reducing the blood cholesterol, which is great. How about it reduces the absorption of sugar and the blood glucose, and then you need less insulin. It works all the way around. Another multi. What signs and symptoms will alert the parents of the possibility of ketoacidosis? What is ketoacidosis? That means the body's not using the sugar, the carbohydrates. And we're eating what? We're eating proteins and fat, and ketones are being produced. You will be nauseous, you'll have fruity breath. Absolutely. Chest congestion, hyperactivity has nothing to do with diabetes and diabetes ketoacidosis. Another multi. Why are children more prone to insulin reactions? So it's about children are just, they don't do the same thing every day. You know, they're still growing, and we know the body accepts food and insulin differently than adults. Proper hand hygiene process should take a minimum of what? Don't you sing happy birthday when you wash your hands? That's what they tell you to do. You know, you've had enough. So how many seconds is that? And that is 15 seconds. A rash that is erythematous, circular raised lesions is caused what? Erythematous is another word for reddened. And that is called papular. I'm giving you the names of rashes because these are some definitions that you're going to need to know. What type of precautions are necessary with varicella? Well, what is varicella? It is chickenpox. So how do you protect yourself and others? It's all airborne. I mean, this is something that I didn't know and realize, but it's all airborne. It's not contact, believe it or not. What is most likely way child contracted hepatitis A? How do you get hepatitis A? Is it blood and feces and body secretions? And that's what you think of when you think of hepatitis, right? But hepatitis A is the shrimp, okay? Different ways of contracting it. Which vaccine would be contraindicated for an 18-month-old child allergic to eggs? And it's the influenza. Good. A child's rash was present on the trunk, extremities, face, and those cheeks were bright red. What type of rash is this? It's what we call slapped cheeks, those bright red cheeks. Slapped cheeks. It is called fifth disease, and it is viral and it is contagious.
What's roseola?
Type of measles. It's a red rash. What are the most likely reasons a female adolescent with STDs resists reporting the condition? So you have an adolescent who has some sort of sexually transmitted disease, and they're like not wanting to go and take care of it. No, actually, it is all the answers here. She doesn't want to tell who it was. She is embarrassed, and she don't want them to do that pelvic examination. She's really frightened of it. And also confidentiality. Are you going to tell my mom and dad? Roseola is a viral thing, okay? And it's a little fine little rash that goes on, and we treat it just like a virus,
So-
okay?
So all the answers were correct? Because I picked all of them and it said, and it marked
I
the whole
know
thing
because
wrong.
I have it miskeyed. I apologize, but it is all of them, okay? Sorry, made you miss one. Forgive me. A child is in the prodromal stage of varicella. What does this mean? Remember, varicella is chicken pox. We know that chicken pox, you have a stage where that you're spreading the disease but don't have the rash. And then you get the rash, and then all the rash heals up and there's all dry, and then you're not contagious anymore. Prodromal, you've got the disease, but you don't have the rash. It's not evident yet. This is when children spread the disease around because you don't see it yet. You don't know you have it yet. When should a hepatitis B vaccine given to an infant born with hepatitis B positive mom? Well, we know this is given at birth, right? That's, part of this. It's the first vaccine we give. But the mother's hepatitis B positive, does that make a difference? And it does. We need to give it within 12 hours after birth to prevent that child from being positive hepatitis also. Which classification of medication would make a child most susceptible to an opportunistic infection? So this medication, I take it, I'm basically immunosuppressed. That's another word for more susceptible. And those are your steroids, your corticosteroids. They make you more susceptible. It decreases your, immune system. A multi. What will the nurse instruct the family to prepare in a disaster kit in case of an emergency? I get a lot of hurricanes down here, and there's many things I do depending. I lived through Hurricane Andrew. That was pretty horrible. But you need to have non-perishable foods. If you have pets, kids, make sure you have diapers, you have formulas, whatever, blankets, small TV. That's not what you need. It would be nice. It's more like a little handheld radio, they say. And of course, medications have at least, a 2-week supply, they say. Which finding would lead the nurse to delay the administration of DTaP for an infant? So DTaP, given at 2, 4, 6 months. If you have a fever, you can't give an immunization. That's why a lot of children's immunizations are behind, because they're sick. And last one, a multi. What sources are examples of acquired immunity? So how do I get my body to be able to fight off some sort of disease? Basically, that's what the question is asking. I have an acquired immunity. How did I get that? And that's because I took the vaccine or I already had the disease and my body built up the defense. Good job, guys. Number 3, look at that, KM. Number 2, Markeia. Number 1, Emily. Good job, Emily. And then we have Pinky and Nurse. All right. Let me get out of here.
Do you post the Kahoots?
every single week, I post it on your announcements and I
Okay.
post it with the recording. They're all there. And then before exams, I'll post every week's Kahoot along with the recordings of the reviews as they come. They're always there.
Okay, thank
Right.
you.
No, you're very welcome. Any questions from anybody? Okay. Ellen, can you come on camera for me? And Markeya, Pinky, so I can see you, so we can do our exam, please, our quiz, please. Very good. Ellen, where are you, my dear? There you are. And I know Kara has issues with her internet, so she's already notified me. I want you to go to your modules and get to your quiz 5. You've heard everything, okay? Take your time. There's quite a few select alls. And don't say because only one, that's not, there has to be more than, or if there's 4, think, oh, that's too many. So just look at the questions and answer it the way you know, okay? And I wish you good luck. Anybody who wants help with the exam next week before, let me know after you look at the reviews and I'm going to help you, okay? Just make an appointment and we'll go over concepts to get you through this course, okay? When you are done, we are done for tonight. So, good luck.
Vicky, do you know if Miss Bogart is still up here?
Oh, say it again. I think.
I said, do you know if Miss Bogart is still up here?
I think it's only us. I think. I just got done. Sorry.
No, you're okay. She made me the host of the meeting, so I didn't want to
Oh,
hang it up.
I'm not sure. Oh, she wanted to talk to you or something?
No, it just, when I was taking the quiz, it said, you are now the host of this Zoom.
Maybe she left then.
Oh, okay.
Okay.
All right.
Okay. Bye.